Dear Chairman, dear ladies and gentlemen, is cardiovascular magnetic resonance helpful for assessing RV performers in athletes? This is my conflict of interest slide, which I believe is not relevant to this talk. Most of you may know that Fabrice Muamba, a football player for Bolton Wanderers, collapsed with ventricular fibrillation on the 17th of March 2012 when they were playing in the FA Cup, Tottenham Hotspurs. Now, he had to be shocked numerous times, and my colleague Andrew Diener was at the football pitch as a Tottenham Hotspurs fan and helped get Fabrice Muamba to our London Chest Hospital, where then Dr. Mohidin continued to look after Fabrice Muamba. And despite a very prolonged downtime, he made a miracle recovery. Now, I'm telling you this story to demonstrate that sudden cardiac death in athletes is real, or aborted sudden cardiac death, as in this case. But it's important to bear in mind that it remains a very rare event. 1 in 200,000 a year, 1 in 50,000 a year, depending on which literature you use. Non-traumatic exercise-related deaths are to about 80% attributable to cardiac causes, but when such an event occurs, aborted or sudden cardiac death, it has a major emotional impact on family, survivors, relatives, friends, etc. These are data from an article published in Heart 2009 on the causes of sudden cardiac death in athletes in the UK when related to the heart. And this talk is about the right ventricle, so I just wanted to point out that in the UK about 14% of sudden cardiac deaths were thought to be related to arrhythmogenic right ventricular cardiomyopathy, or ARVC. The next few slides I'm going to talk to you about the effects of exercise on the right ventricle, both chronically and in the acute phase. Most of you will be familiar with the multi-ethnic study of atherosclerosis, which was a population-based study with 4 ethnicities, including about 6,000 subjects. Of these, about 1,800 or 1,900 were included in this sub-analysis, where it was shown that higher self-reported levels of physical activity are associated with greater RV mass and RV volumes, which proved to be independent of LV mass and other confounders. And you can see these relationships here between RV end diastolic mass and RV end diastolic volume. Now, my previous colleague Jürgen Scharhack assessed in a smaller group of male athletes the relationship between VO2 max as a measure of performance and right ventricular mass, and found a very strong correlation with an R of 0.85, which was highly significant. In sports cardiology or sports physiology, very often one assesses whether dilatation of the heart occurs in a balanced fashion and hypertrophy of the heart, which is thought to be supportive of the notion that changes in athletes that we see in terms of cardiac remodeling are physiological or benign rather than pathological, as we, for example, see in hypertension or arrhythmogenic right ventricular cardiomyopathy. Now, from our study, we looked at male and female athletes, elite athletes, and basically plotted a ratio to assess this balanced cardiac dilatation and hypertrophy for LV and RV. And interestingly, there were no changes in function between left and right ventricle, between non-athletes and athletes, both male and female. There were no changes in the ratio of dilatation between the left and right ventricle for athletes versus non-athletes, and therefore also no difference between male and females. But very interestingly, there was a significant change due to training for both male and female in terms of the LV-RV ratio of mass index. So what this shows is that if you train a lot the LV hypertrophies more than the RV for a given amount of training. So there's what we found is basically balanced cardiac dilatation but unbalanced cardiac hypertrophy. Now, this study looked at a similar thing in athletes, in sprinters and marathon runners. What they found is that increased RV mass was present in all elite athletes, so you can see that here as an increase compared to controls for both marathon runners and sprinters. But there was no change in function. What they did find, interestingly, was that the right ventricle dilates more than the left ventricle in sprinters. Now you can see that here is the LV-RV end-diastolic volume ratio. This was smaller than controls, which means that the RV dilated more, but that wasn't found in marathon runners. Interestingly, they found amongst all their athletes no change in the LV-RV mass ratio, i.e. they found that there was balanced cardiac hypertrophy amongst all athletes, unlike what our study showed. Yet another study looking at the chronic effects of exercise, Lagerche and colleagues published in 2011 found that the right ventricle is preferentially remodeled compared to the LV when you compare endurance athletes with non-athletes, and that just note that the ratio here is the other way around, so it's RV over LV ratio. What you can see here is that the right ventricular end-systolic volume is more increased than the LV end-systolic volume. Similarly, the right ventricular ejection fraction is more decreased compared to the LV ejection fraction, and RV mass is more increased compared to the LV mass. So this unbalance of favoring RV is more in line with what we found, even though we found a more pronounced LV hypertrophy compared to RV hypertrophy. Now, the same study then looked at potential explanation factors that could explain those chronic changes that preferentially affected the right ventricle. So what Lagerche looked at is they used athletes and non-athletes and assessed the end-systolic wall stress for both LV and RV in all subjects. And what they found is that the RV end-systolic wall stress is significantly lower at baseline for the RV than the LV. But at peak exercise, there was no significant difference. And that means that the slope of change, the relative increase, is significantly larger for the RV compared to the LV. They now wanted to see whether there's a difference in this behavior between athletes and non-athletes, and they plotted the exercise intensity in watts on the x-axis with the RV systolic wall stress on the y-axis, and found that the regression lines between athletes and non-athletes are essentially the same. So there doesn't seem to be a difference between athletes and non-athletes in this relationship. The only difference being that athletes can exercise more, can have higher exercise intensity, and then still show further increases in the RV systolic wall stress. So what this shows is that acute effects on the RV wall stress are more pronounced than in the LV, and these changes are proportional to the intensity of exercise. Now, the authors conclude that maybe acute effects could be responsible for chronic, more pronounced RV remodeling in athletes. The same group did a further assessment for acute and chronic effects of exercise, and they wanted to know whether these changes that we see are physiological. They looked at a very special group of athletes that actually do extreme bouts of exercise, from marathon running being the sort of easiest one, 3 hours at a time, to ultra triathlon 11 hours at a time. What they found is in post-race that RV volumes increased, that the right ventricular ejection fraction and strain decreased. You can see that example here between baseline post-race and then delayed. You can see the reduction in ejection fraction, which then recovers 1 week after the race. LV volumes decreased, but the LV ejection fraction was unchanged. All this was accompanied by BMP and troponin rises, and very interestingly, they observed that post-race, a little bit post-race, there were 5 athletes who had new late gadolinium enhancement, indicating some form of myocardial injury, and suggesting that maybe those changes we see aren't entirely physiological. Similar study or sort of findings by the Royal Brompton Group, published in 2011. They looked at veteran athletes and found late gadolinium enhancement in about 50% of them. And they found that the presence of late gadolinium enhancement was associated with the number of years spent training, again, suggesting that maybe not all changes we see in athletes are physiological. But how about those subjects, those athletes that actually already present with some complex arrhythmias? This very intriguing study by Hein Heidbucher, published in the European Heart Journal already 9 years ago in 2003, looked at 46 endurance athletes with complex ventricular arrhythmias that originated in the right ventricle, because they presented with, most of them present with the left branch block pattern during the tachycardia. Because this was published in 2003, it didn't use the new ARVC task force criteria, but they used the McKenna criteria and found that in about 60% of those endurance athletes, the ARVC criteria were positive. There were lots of major arrhythmic events. About 40% of the athletes had major arrhythmic events, including 9 deaths over a 4.7-year follow-up period. They assessed whether any of the baseline measures could predict the outcome, and found that no outcome could be predicted by presenting symptoms, non-invasive arrhythmia evaluation, or morphological findings at baseline. But they did find that during the electrophysiological studies in the cath lab, inducibility was a poor predictor. So there was a difference in the freedom of ventricular tachycardia or sudden death between those that didn't have inducible arrhythmias and those that did have inducible arrhythmias. Another study by Biffy looked at a similar cohort, 37 athletes with ventricular arrhythmias but no other cardiovascular abnormalities. And they basically plotted the number of ventricular premature complexes over 24 hours monitored on Holter monitors in those subjects, and found quite a spread, but also a significantly sort of increased VPCs over 24 hours, which then completely disappeared when these athletes deconditioned, detrained. Interestingly, they were then introduced to training again over a period of a year, and the numbers of VPCs on Holter monitoring increased over time, but never reached the levels at baseline. Furthermore, there were no cardiac events or symptoms at year 1 of follow-up. The authors concluded that this sort of underlines the benign nature of such arrhythmias in elite athletes, and is very different to this study published by Hein Heidbucher that I showed you on the previous slide. What this study cannot answer, but what I would like to raise, is could the lack of arrhythmia reversibility be a marker of poor prognosis? Certainly, if this is the case, it's not a very attractive marker, because athletes do not like detraining. So we really need to continue to strive to find predictors of adverse events without asking athletes to detrain. Now, these are the proposed modification of the ARVC task force criteria published in Circulation by Marcus and colleagues. Most of you will be familiar with it, but they basically have 6 categories. In each category you can score a major criterion or a minor criterion. Major criteria will get 2 points, minor criterion will get 1 point. You need at least 4 points to come up with a diagnosis of ARVC, but they need to be from different categories. It includes family history, arrhythmias, ECG changes, repolarization abnormalities, depolarization, conduction abnormalities, tissue characterization of the wall in using endomyocardial biopsies, and it uses global and regional dysfunction and structural alterations with either echo or cardiac MR. Now, this study here, Vermes, summarized nicely the cardiac MR criteria that can assess this category and compared original criteria with revised criteria. And I'm not going to dwell on the exact numbers, but just to reiterate that it's a combination. To get a major or minor criterion in this category, you need to have a combination of regional RV akinesia or regional dyskinesia or dysynchronous RV contraction in combination. So these wall motion abnormalities in combination with reaching and having an increased right ventricular end diastolic volume index or a reduced ejection fraction of the right ventricle. And these numbers differ whether you're a major criterion or minor criterion between males and females. So it's the combination that's important. Now, this study by Luix looked at these new modified ARVC task force criteria in athletes and simply plotted between ARVC patients, healthy athletes and healthy non-athletes, how frequently these minor and major task force criteria were present. As you would expect, in ARVC patients, there were extremely high numbers. In a high number of subjects, these were positive. But very interestingly, they were extremely frequently positive in healthy athletes and even positive in a large subgroup of healthy non-athletes. So we talked about balanced cardiac dilatation. In ARVC, you would expect the right ventricle to dilate more than the LV. So you would expect unbalanced cardiac dilatation, whereas in athletes, a lot of the studies I showed you earlier suggested balanced cardiac dilatation. So they wondered whether introducing a new cutoff for an LV-RV end diastolic volume ratio would be better to distinguish those ARVC patients from healthy athletes, and lo and behold, they found that they can differentiate these much better using a ratio. But what they are sort of not emphasizing in their paper really is that the RV wall motion abnormality, which is one of the two prerequisites to get a major or minor criterion based on cardiac MR findings, is that the wall motion abnormality was present in about 91% of the ARVC patients, but in none of healthy athletes or healthy non-athletes. So, in fact, the combination is still a very good way of looking at it, but still it's worth bearing this in mind. The RV end diastolic volume index, which is part of the task force criterion, was performed much worse in differentiating athletes from ARVD patients compared to the ratio of end diastolic volume index. Now we have advanced cardiovascular imaging techniques to assess the right ventricle, which may help in the future to learn more about differentiating athletes from ARVC patients, or to understand the physiological or pathological nature of cardiac remodeling. Cardiac MR can use tissue phase mapping, feature tracking, late gadolinium enhancement, or T1 mapping, just to name a few. In echo, 3D helps speckle tracking. And I'll show you some cardiac MR tools. This tissue phase mapping was basically further developed by Bernd Jung in Freiburg. Here for the LV, you can, because of high temporal resolution and spatial resolution, you can get very, very good myocardial velocity curves in the radial, circumferential and longitudinal direction. You can do similar things in the RV because of this high spatial resolution. Another option is feature tracking. So TomTech in Germany allows measure deformation to be measured directly from steady-state free precession cine images. The software tracks features such as the cavity boundary or tissue patterns related to the endocardial or epicardial contour over the cardiac cycle. This then allows you to determine ventricular strain, strain rates, velocities, displacement, time to peak analysis, mass or volumes, and you can get similar measures for the right ventricle. I'd like to thank Dan Augustine, one of my research fellows who works in Oxford, who's provided me with these examples of an athlete using this TomTech feature tracking tool. But you can also look at these, do this analysis in the RV, and here we've got an example of an athlete who has an RV free wall segmental strain of an average of 19%. So you can see 3 different segments plotted here. In conclusion, prevention of sudden cardiac death in athletes after years of research is still imperfect and remains very topical. Sudden cardiac death in athletes is rare but has a big impact on family and friends. Acute and chronic right ventricular changes to exercise are likely to be benign, but data are conflicting and complex. Modified ARVC task force criteria published in 2000 in Circulation in athletes is robust. Regional RV akinesia or dyskinesia or dysynchronous RV contraction must always be present in combination with reaching one of these cutoffs for the right ventricular end-diastolic volume index or right ventricular ejection fraction, and it may well be that ratios of RV-LV dilatation are better for athletes' ARVD differentiation, but certainly if you look and make as this is a compulsory part of the cardiac MR criteria, it actually is robust in my mind. Novel cardiac MR techniques may provide incremental value to existing methods in assessing athletes in the future. With this, I'd like to thank all my colleagues at the London Chest Hospital, and particularly Ian Stone, who helped me do some of the literature search and helped me put some of the slides together. I'd like to thank you for your attention. Thank you very much.